Hi guys, my name is Stella and we're back again for another set of pneumothorax lecture or presentation. So we stopped at risk factors from our previous video lecture. So we're gonna start about with gender. So male are more prone on having pneumothorax because young male adults are more prone on having an MVA or motor vehicle accident. So um, in a article that I've read, males are more prone on having a pneumothorax. Age, older older people tends to have pneumothorax more often rather than middle aged because their lungs is more fragile rather than us in the middle age. So smoking history is a big deal because our lungs. So in a smoker lungs, they are more fragile because um, basically the entire lungs is being cooked up from all of the heat and the smoke that the smokers are inhaling. So basically their lungs is super fragile because it's being cooked up or some of it is already necrotic. Lung diseases, as I said earlier, ARDS, restricted diseases, ILD, COPDers, they are more prone to having pneumothorax because of the lung problem that they already have. Genetics, there's no indefinite articles that's saying that genetics, it's a genetically, can be passed on genetically, but in our book it says genetics because some people that had pneumothorax before, apparently they're like passing it through their sons or daughters. Mechanical ventilation, as I said earlier, too much pressure that we put in or too much volume that we put in, we could pop up those lung units and create pneumothorax. So we have to be very careful on setting the tidal volume or the PEEP that we are putting into the patient or the pressure that we are putting into the patient. And pneumothorax history, because a lot of people that had previous pneumothorax, they somehow have a reoccurring one whenever they get sick. Excuse me. So some tests and diagnosis. Physical exam. So for physical exam, we have VQ ratio decreases due to reduced alveolar ventilation. So our VQ ratio will decrease because, again, as I said earlier, there's atelectasis and there is some compression of the greater veins. So there's not much blood flowing through and there's not much air going inside, so the ratio will go down. We also have decrease in lung compliance because, as I said earlier, it is more of a restrictive because when you have a puncture in your lung and there's a lot of air outside of it stuck in the pleural space, there's no way the gas or the air that's inside the pleural space will come out. So it's more of a restrictive because we don't have any more compliance to go back, to go or expand because it's already expanded and there's no way to come out or go back. We also have pain and anxiety because patient can't breathe, increased heart rate and blood pressure, and we have cyanosis. We also have chest x-ray, blood tests, ultrasound, CT scan, and PFT. So we can do all those and I will explain some of it on the upcoming slides. So complications. So as I said earlier, a lot of people that had pneumothorax previous could have a recurring pneumothorax, or it could occur again when they have let's say, another lung problem, they could have, there are more potentially, or there are more percentage of them having a pneumothorax again. And air may sometimes continue to leak if the opening in the lung will close. So if the puncture in the lung stayed open and we don't do anything about it, it could go into more. They could potentially go into a code in a sense. So after that, we have management or treatment of pneumothorax. So managing pneumothorax, there's not much of a treatment that we could do for them. It's more of a pain management and helping them to breathe, as it says in their oxygen therapy, lung expansion therapy, and mechanical ventilation. So it's basically helping them just to alleviate the pain and help them to breathe. And we also can do chest tube. That's another management or treatment for a patient. That way we could release the air that's stuck on the thoracic, on the pleural space, excuse me. So before I move on to medications, I just want to talk about the ultrasound versus chest x-ray. So I read an article about it, and it says that, again, chest x-ray is much better than having an ultrasound, because chest x-ray is much faster and it gives us a clear picture of what's happening on the entire lung. So let's move on to medications. So there's a couple of medications, as you would, so you can notice in here, local anesthetics, opiates, analgesics, benzodiazepines, and antibiotics. So those three, the anesthetics and the benzodiazepines and analgesics, it's basically for management of pain. Antibiotics, just, to prevent any kind of bacteria or infection that could happen. And then the talc is basically medication that we use to help close the lungs. That way we could prevent more pneumothorax, and it also helps connect the pleural space into the thoracic cavity again. Excuse me. So for vital signs, we will have increased heart rate, because most of the times, or a lot of times, the patients are in distress or anxiety. It increasing respiratory rate, and the pattern, because the patient, as I said earlier, they can't breathe, so the patient will have more. They will increase the respiratory rate to compensate into the breathing. That way, they could send more, oxygen into the bodies. And then, anxiety also plays with it, because when you're in an anxiety state or in distress, respiratory rate tends to go up, and the pattern changes because of the chest rise, so it'll be more asymmetrical. Blood pressure will also be increased because of the anxiety level, and then lung sounds on the area of the area that has the pneumothorax will be decreased. PFTs, this will show us more of a restrictive pattern, as I said earlier, because there's a restriction in the breathing, because the air is getting stuck on the thoracic area or the pleural space, so it's more of a restrictive, because there's no way of air getting out of the pleural space. And tidal volume can be potentially normal in an acute small pneumothorax, and it could be decreased also, but in a large pneumothorax, this will be really decreased, because there's not much air in one lung unit rather than in the other. Total lung capacity will decrease because, as I said earlier, puncture in the lungs, air is coming out and getting stuck in the pleural space. Vital capacity will be decreased as well, FRC and RV, or residual volume and functional residual capacity, will be decreased again because there's nothing much air that's being left out in there. That's why we have atelectasis. Excuse me. So for our laboratory information, we only have ABGs for this one. I'm gonna talk about this on our next video. Thank you.